tonight we have Dr. Aaron Johnson, a colleague from the University of Maryland School of Medicine, who has clinical interests in both hip and knee arthritis, post-traumatic arthritis, and complex hip and knee arthroplasty. In this case, revision hip and knee arthroplasty. He's a member of the University of Maryland Joint Network, a group of surgeons who are, as you can see here, known for their advanced expertise and outcomes in total hip and knee replacement. Welcome, Aaron. How are you?
I am well. Thank you very much, Mo, for having me, and excited to chat about knee arthritis a little bit.
Yeah, why don't we? Why don't we just get started? So I've got a couple of broad questions, and I put these questions up just because people will probably come and go throughout this 30 minutes, and so they know roughly what we're talking about as we go forward. But let me just start off by asking you, when we talk about the spectrum of opportunities and treatments for patients that you see in your practice, can you walk us through just the broad range? It obviously needn't be exhaustive, but what are the general categories of treatments that you're offering your patients right now in 2022?
So I'd say I see a broad spectrum of patients that range anywhere from minimal arthritis and nowhere close to needing any sort of surgery to terrible end-stage arthritis, and they can't get their surgery fast enough. For the most part, I'd say my patients tend to be older, and they tend to be patients who have more advanced arthritis just because of the nature of my job and the referral system of how we are. So I'm not seeing as many younger early stage arthritis patients.
Got it. You got it. And now, I mean, obviously you probably have slightly different plans, but among the tools you use or in helping manage these patients, what broad categories of therapies are you recommending at this point?
So in the patients who don't meet criteria for surgery yet, and I'd say there's also another category of patients who are sort of either radiographically meet criteria for surgery, but they're not emotionally ready for surgery. And then there's a group of patients who are sort of so high risk that they're not quite optimized yet. So that's sort of my role for non-operative treatment is either to bridge you to your surgery or to try to palliate the symptoms in such a way that you can get around and live life because you may never be healthy enough to have a surgery. And the things I offer, it's a range from, over-the-counter anti-inflammatories, Tylenol, bracing options. A lot of my clinic is also a weight loss clinic. So I do a lot of diet management. For us in particular, we don't have great access to nutritionists, so I do a lot of nutrition counseling with patients. I do a lot of discussion about sort of low impact aerobic exercise, things that they can do to stay active, maintain the quadriceps strength so they can do normal activities of daily living without pain, and then start getting into some more adjunctive treatments, which would be slightly more invasive, such things as injections, which for me is mainly cortisone injections. And then occasionally we'll get into some hyaluronic acid injections for patients who are really trying to sort of avoid surgery. And then surgery is really sort of the last resort when all of these other things have failed.
And I take it at this point, you sort of the arthroscopic lavage is it's just out, right? I mean, I know there's still people doing it a lot, but I imagine from your perspective, it's not something that you put as part of your treatment algorithm.
Yeah, that's for me, that's out of my treatment algorithm. Most people are getting to me, they're so far down the arthritis pathway that I think it's pretty reasonable at this point to say that arthroscopic debridement is just going to advance the arthritis worse, even though everyone has sort of anecdotes of somebody who had a debridement, had a meniscus debridement, and they felt better, and maybe it bought them time, but that's not really in the armamentarium of how we're treating arthritis, at least for us right now.
Yeah, so I'm just going to quickly share with you, like this is now some years ago, as you can see, it was 2015, I can't remember. It's in that part, it was about several years ago. But the funny thing is the evidence has pretty well stayed the same. This is a study we did in the Journal of Bone and Joint Surgery, and this is just a host of the different types of treatments. That red line there, I'll talk about it a bit later, but is Above that line is what we call both a statistical and a clinically important difference. But if you look at across the different therapies, there are so many out there. I've highlighted, just for the sake of discussion later this evening, the PRPs, the hyaluronic acids, the corticosteroids, but you can see there's bracing, there's TENS, there's, a host of, glucosamine, acetaminophen, oral treatments. There's a bunch of stuff here, valgus bracing, all the things I think you've talked about that really represent opportunities for engaging. A lot of these actually still have some degree of benefit. The question is how much benefit, and ultimately where you start using some of these non-operative approaches. As you mentioned, there's, depending on the type of patient. I think you've answered this, like for your sake, it looks like you've got, groups of patients that are either coming early and those that are coming a bit later to you. It seems that they come very late. I mean, are you, for that particular group of patients, are you pretty well resolved to moving right into the idea of a of some sort of, either, in this case, it would be a knee replacement surgery, or are you still considering non-operative treatment? Someone comes in who has not tried much, for whatever reason, hasn't tried a lot, even in the severe cases. What's your algorithm for that group?
I really try to talk to the patient and get a feeling for what their goals are. Sometimes the younger, more active patients who want to continue doing high impact activities, and if they haven't had any sort of non-operative treatments, I'll try to exhaust whatever we can in terms of anti-inflammatories, getting them a brace for their activities. And those are the people that I find will get the gel injections on a pretty regular basis, to try to spread out that time so that they can continue doing the stuff that they want to do before being, somewhat activity limited by a knee replacement. So I sort of leave it up to the patient, and I try to get a sense of what they want to do. If they say, hey, look, I don't want to take a pill every day, I don't want to come in and get injections, I hate needles, braces don't stay on my leg, I just want to walk up and down the stairs and hold my grandchild and not be in pain anymore, then, those sorts of people, I think, may be more better served by surgery, because they want a more permanent solution that doesn't require maintenance and upkeep.
Now, you mentioned a couple of things that are of interest, I'm sure, to some of those who are listening, which is, you mentioned broadly gel, and I'm presuming gel, you're talking about hyaluronic acids of some sort, and we can talk about specifically a bit later about which like in terms of characteristics of an HA that makes sense. But regardless, you said they come in for multiple injections. So is that, like, whether it's HA or a corticosteroid or some other non-operative treatment, even in the more severe patients, that can still be an offering to delay potentially, if they're not at a point where they're thinking surgery? Or is it just someone you're trying anyway to decrease pain and see if in fact you can leverage a bit more time? So much of this is about leveraging time and lengthening the period of time before going to a total joint replacement. Is that partly your goal?
I think that's a lot of my goal, and I think you sort of hit the nail on the head, right? It's leveraging time.
Yeah.
And I can think of two 50-year-old gentlemen that I saw this week who one of them runs his own construction business, and the other is an auto mechanic who does skydiving and ultra marathons and is just sort of a fitness nut outside of being a heavy laborer. And both of them come see me every 3 months for their injection, and they love it. They're like, I don't want surgery, I want to put this off as long as possible. And they get 2 to 3 months of relief out of their injection, and every 3 months they're back in my office. And they have end-stage bone-on-bone arthritis, 20-degree varus deformity, but they are not interested in surgery. And as long as they're still getting any relief out of that injection, they will put it off as long as possible.
Oh, that's interesting. Okay. And for the patients who come in with early stage knee OA, same general approach. I mean, you're obviously maximizing non-operative treatments. Same sort of thing. I mean, are you using kind of like, is there a stepwise approach, which sounds like, there's a weight loss program, there's issues of, sort of NSAIDs and things like that, topical NSAIDs, and then moving kind of sequentially before you get to injectables, and then after injectables, you keep moving forward? Or do you sometimes just go right into one treatment or the other, depending on the patient's preferences?
For earlier stage arthritis, when they still have some remaining joint space and some healthy cartilage left in their knee, I actually will try to not do as much invasive stuff. And I try to keep them on either anti-inflammatories, bracing, weight loss, and I'll actually minimize injections in those patients for any sort of cartilage injury concern. There's some reports that injections in earlier arthritis may be less effective than a placebo injection. So for those people, I actually try to space it out more and minimize the amount of injections that they're getting, whether it's cortisone or HA.
Got it. And just so I'm clear, you said cartilage injury. With cartilage injury, am I presuming you're thinking concerns about corticosteroid in that case, or is it any injectable? Okay.
Mainly corticosteroid.
Understood. Okay. That's actually very helpful. So, I mean, take a look at this. I suspect those listening in have probably seen this paper. I mean, with COVID particularly, we've had massive backlog around the world. They talked about some 28 million cases being deferred over that 12-week period. And, between March, and I think it was that 12-week period around March 10th, 11th of 2020, when they declared it as a pandemic. What's your thoughts on this sort of analogy for, it's a state worse than death waiting for hip and knee arthroplasty, and this group is nearly doubled, and, we're trying to get the backlog, which makes it come to the broader question, what's success or what's considered a failure in the management of knee OA? Maybe you can flip it either way, however you want to take that. The patients who fail, what's unique about them versus the patients who are quite successful? I'm sure you've had some thoughts on this.
So it's interesting, back to your previous slide, worse than death waiting for their joint replacement. It sounds like a bit of a catastrophization, but yeah, I see these people also. They're like, I waited 2 months to see you and I can't get surgery for 6 months now because of COVID. I can't live like this.
Yeah.
And for those people, it is life altering. And how do patients define success? And I think for arthritis patients in particular, it's a very patient-specific conversation that I have with them. You asked who fails or who doesn't do well. I think there's the obvious actual problems, infections, dislocations, implant failure, but who's happy after a knee replacement? Those are, or who's unhappy after a knee replacement. And I think a lot of it is reality expectation mismatch. So a lot of what I do when I see these people is I try to get a sense of what is it you want to be doing and how can we get you back to that. And I think most people have a very reasonable expectation of what they want to be doing. Most people say, I want to be walking, or I want to play pickleball, or I want to get back to golf. And I think those are the people that tend to do very well. And if that means that you get an HA injection once every 6 months, so you can get back playing pickleball with your valgus unloader brace on, fantastic.
Got it. And let me ask you this. So from the context of, quote, definition of success, it sounds to me it's very individualized with you. Like sort of the tenets of EBM is it begins and ends with the patient. It's patient-centered care. Patients define what are outcomes that they want to do. And I think in many ways, patients don't think of, well, I'd like to be 10 points better on the Womack scale. They don't say that to you.
Yeah,
what they say is, they say, I want to get back to playing pickleball, as you said. Yeah. So when you think about the function as being a critical definer of outcome for patients, is it pain as the primary factor? Like, is it just variable? Is it some patients just say, I don't mind the pain, I just can't walk long. But walking, and I think they're very highly correlated. Curious what your thoughts are. Like, what are the outcomes that, if you were thinking about the patients you have in measuring, which are the ones we should be measuring more often? And maybe we are just more getting a sense on, what are they?
I think pain is the driver. And if we can improve their pain, I think all of these, whether it's a pill, whether it's a supplement, whether it's a brace, whether it's an injection, whether it's surgery, I think the goal of all these is to decrease the patient's pain, because my sense is that the reason they don't do the activities they want to be doing is because things hurt. Very rarely do I see somebody where they have an awful looking knee and they tell me it doesn't hurt at all, I just want it to move more. So some of the things that are more easier to measure, such as function, range of motion, it's unusual that someone comes in and says, I want to be able to do yoga, or I want to be able to flex my knee like I could when I was 20 years old. And when those people come in, I try to have a very frank conversation with them and say, hey, look, I can't make that better. but I can make your pain better so it doesn't wake you up at night. I can make your pain better so that you can do the activities that you want to do with your family and your friends and not constantly be interrupted with the pain from your knee.
Yeah, I totally makes sense to me. And I think the challenge often is if you look at the most non-operative treatments that have been approved through the FDA. If you look at the FDA model, I mean, the driver has been 12 weeks pain. Do you have an impact on pain? Function's also becoming important, but the idea of saying, well, I'd like you to lose weight and start moving. Patient tells you, right, I can't move, I'm in too much pain. What do you do there? I mean, it seems to me like there's this vicious cycle of saying, well, you have to lose weight, and then the pain will go away, but I can't lose weight because I can't move, I can't walk around.
Yep.
Help me with the pain immediately. In that situation, do you jump to any non-operative treatment? Do you get a bit more invasive at that point? Whether it's corticosteroid, whether it's HA, maybe PRP or anything. Do you use any of those to kind of stop the pain cycle to get them moving? Which in theory, all the guidelines say, well, you use them as second line. But I'm curious in practice if that really happens.
I think it does. And those people, for me, the bucket that is the people who are would benefit from a knee replacement, but they're not optimized yet, right? So they're either from a nutritional weight standpoint, whatever it is, they're not there. And those people absolutely benefit. I mean, I still counsel them on all those things that you talked about, the weight loss, the exercise, the low impact activity, but I'm pushing them towards either a cortisone or an HA injection.
Got it. Okay. I mean, and I think, we talked a little bit about this. I won't belabor this point, but if I go back to this figure again, and you look at this data, and now take it at face value. I mean, this is not my potential data. This is the data from randomized clinical trials that are comparing against each other. When you look at this and you look at, let's just start with the corticosteroids, right? So if you start with the red line here, anything above that line is considered above what we call the minimal clinically important difference. So if one of these, let's take a corticosteroid. You see here, the average effect is above that, but you see the confidence interval suggests that the truth could lie anywhere from being, both a clinically important and a statistically significant impact, all the way through to a statistically significant, because that line doesn't touch the bottom, so it's significant, but it's not hitting a threshold of clinical importance. That, in comparison, let's say, to the lower molecular weights, you see it's a little less effective. And if you look at the higher molecular weights, you see that they seem to be doing better average effect. And also the confidence interval suggests that in most cases, it's a bit more precise. You're more likely to be able to have a concerted clinically important benefit. And if you move over to the PRP, it actually has a very high average effect over everything else. But the challenge that we still face, and I think the guidelines still tell us that, and for those of you who are interested, check in tomorrow night, and you'll hear a lot about this. Look at the variability in PRP. Now, you didn't talk much about PRP. You might have your own opinion. But I'm guessing when you look at these three players, do you have any sort of thoughts on the injectables based on sort of the evidence and also based on your own experience with them?
Well, when I look at this, I think I should be injecting more high molecular weight HA.
Yeah. No, and again, I wish I could say this is my insight. This is just the evidence that we've faced. Now, people can take it or leave it, but my take is that also corticosteroids aren't as bad as we think in terms of the impact. I know there's been some papers on it, and again, tomorrow we'll talk about those in a separate session. But the truth is the corticosteroid effect is a real effect, and it happens for short-term use. The problem is, I think you're alluding to, patients who need it multiple times, maybe you might flip it to something else. And we haven't even talked about the combination therapies. You can use corticosteroids with HA that can give you the best of the early effect and the long-term effect. But this is anyway kind of a discussion that we can have offline. In fact, if others have questions about this, feel free to throw it into the message box, or we can erase it shortly. But this is kind of the approach, at least on the evidence that we have. But let's just sort of
going back to that slide just for a quick second. What I end up using more for my practice decision making is sort of cost and ease of how easy it is to use these for the patients. So in the office, when somebody comes and sees me, I have a closet full of corticosteroids because it doesn't require insurance pre-authorization. So the big barrier that I have for me actually in treating and using this, using the HA injections, is that it requires 2 office visits for the patient, because they have to come, they have to see me, we have to fill out insurance authorization, and then they have to come back a second time for their injection. So it's better than it used to be, where we had to give a series of 3 or 5 injections with the HA. So, a lot of them come in a single injection
for sure
pack now, but it still does require 2 visits. And a lot of the patients don't really like coming back 2 weeks later, 3 weeks later to get their injection.
Yeah, I mean, in the absence of, and there's some real issues, right? There's some issues with, access to any of these treatments. Let's assuming they were equally available and price and cost wasn't an issue. I always say that as a broad thing, like what would be the evidence-based decision making? The challenge, I always say, the corticosteroids, there's evidence for use. I know there's concerns, but there's still evidence for their use. Quite frankly, I mean, if you look at the HAs, and we can see it here, I think the higher molecular weight makes a lot more sense. And if you're looking at PRP, it doesn't mean that it doesn't work. It means we just haven't figured the formulation out. Now, there's going to be individuals listening in right now who are saying, no, this works, and this variable works. I always say to them, well, great, publish it. If it works, tell us about it, write about it, do controlled trials, and help us change that large, confidence interval to a narrow one. And it becomes a very, compelling story. But in 2022, looking at all things, you kind of want to go with the safest bet, because people are paying for it, right? If insurance isn't covering it, people are paying for it, and you want to give them the best chance at success. That's all.
And I offer patients the PRP. And I talk to them about the data of the 3 different types of injections that they can get. But PRP is, for us, it's an out-of-pocket cost. So it's
for sure.
It's a hard sell for the state insured patients to come up with,
for sure,
$800 for an injection.
Absolutely, it certainly depends. And obviously, there's been a lot of direct patient marketing about about this being a biological treatment. And I think we have to keep in mind that a lot of these treatments have biological impact, right? HAs have biological impact as well. Infect biology. So, anyways,
I saw somebody last week who had gone and gotten placental cord injection into their knee.
Wow, from where? It certainly wouldn't be Canada.
Yeah, I don't know. Some shop down the street. They're actually infected, but it's fine.
Okay. Well,
so I don't know that I would recommend that just yet.
Fair enough. I think we're a little early for that. A little early.
Listen, I mean, the jury's still out on that one.
Yeah. We've kept this to about 30 minutes. We may stay a little longer if you have any questions, but I don't see questions popping up. What are your key takeaways? I mean, if we're talking, we've tried to do a quick sort of tour of, of the patient journey. What's important, what defines success? What have you taken away about OA management, if you had to put it in a nutshell? And maybe it can't be done. Maybe it's more complex than simple, but I'm sure you've got some thoughts on this.
Yeah, I mean, my takeaway for knee arthritis and the end stage which is typically what I see, which is to get a sense from the patient what they want, and set some expectations with them, and offer them the data about the treatments that we have, and help them to make an informed decision about whether or not they want to avoid surgery and continue with injections versus bracing versus exercise, or whether or not they want to proceed with surgery. Because it's, patients are happy after surgery when it's performed on the right patients. But it's, patients have to have the right expectations for what they want. And I think getting the patients back to whatever they want to be doing without pain is sort of my goal. And tailoring their treatment to each patient is how I try to do that. And I use pretty much all those tools that you showed there on that chart.
Got it. And if I were to just summarize a little bit, and keep in mind also, folks, that we're keeping these as short because we're trying to be particularly mindful of everyone's time. So tomorrow, again, if you have a bit of time and you want to join us for a journal club, which will be pretty high yield paper. So if you're interested in getting a quick tour of the evidence for knee OA, that might be a good session for you to join. And then following that, just about 30 minutes thereafter, we'll be having a discussion with, again, an individual who has led the guideline, the ORSI guidelines, has done so many of the network meta-analyses and has more than enough insight about the various, non-operative treatments that I think the guidelines, on which the guidelines are based. Let me just, if I could, just stop sharing for a second. I know there are some folks here. If anybody has any specific questions that you felt you'd want to chat about, if you have a comment, feel free. I mean, I know we're at 7:31. I don't mind staying a little bit longer if anyone here has a particular question. There's one that's just popped up from Derek. Thanks, Derek. So what criteria do you use to determine the need for surgery?
So need for surgery is bone-on-bone arthritis and pain being the main goal of what they want to improve. The question I typically will ask patients is, does this wake you up pretty much every night? And are there things that you want to do that you cannot do because of pain in the knee? And if the answer to both of those is yes, and they have bone-on-bone arthritis, and they're not interested in doing any sort of other non-surgical treatments, then those are the people that I'll offer surgery to.
Is there ever a situation, just to further to Derek's question, in which someone comes in with pretty severe bone-on-bone, but for whatever reason, haven't really done the full or maximized non-operative treatment? Do you encourage them to try it, even though you know that this, like that they could easily be a candidate for a total joint replacement? What's your threshold for that?
Absolutely. So if someone sees me and they've not had any treatment, I encourage them to start with anti-inflammatories daily, wearing a brace for activity, injections when needed. And I really go through that algorithm on most people, and I encourage them to pursue all of those things before we go through surgery. And so I have a bunch of people that sort of meet those criteria, and then I'll do the non-operative treatment with them, and they may get injections for 6 months. They may get injections for 5 years before they say, you know what, hey, the injections were doing great until that last one you gave me. It only lasted for a day. I'm done with this. I want surgery. Yeah,
that's actually interesting. So John Friedland actually asked a question about, is there a limit? So if someone wants surgery, is there a BMI limit? I know you must have a threshold for this. So because you basically said you had a weight loss clinic at some point. So I presume you have a threshold. Yeah,
I do. So our sort of institutional cutoff that we've determined is you're naughty if you put a hip or knee replacement in somebody above this BMI is a BMI of 40.
Okay.
So
and Aaron, that just so I think the rationale for that is just a much higher complication rate, and there's evidence for the higher complication rate, infection rates, everything else being increased.
Yeah, it's not a stepwise increase, but it is a fairly linear increase, and the overall complication rate is still low, but it does seem to start creeping up as you start getting above 40. Now, if you have a BMI 41 or 42, that's fine. I mean, everyone's knees are also somewhat different, because you could have a BMI 45 but carry it not in your legs. Yeah. And that as something that I'll do for those patients is I'll send nutritional labs. I have a fair number of patients who are recovered from bariatric surgery, so depending on which sort of bariatric surgery they've had, they may actually have some malnutrition and nutritional compromise, so I'll try to get that as good as I can get it before we would do any sort of surgical intervention on them, just from a wound healing standpoint.
Understood. So in that patient population that has a contraindication, you would otherwise offer them, but they're what do you do for that group? I mean, I know you're trying to work with them to try to get their weight down, but is that a situation then where you become very aggressive with non-operative treatments? And I guess in your experience, how's that turned out?
It's great. I have a whole bunch of people that see me every 3 months for their weight check and their bilateral knee injections, and their weight never budges, but they show up and they get their injections, and sometimes they just want cortisone. Sometimes we'll alternate cortisone and HA. Yeah. Sometimes we'll just do HA. Sort of depends on the patient and what sort of response they're having to the injections.
But I guess the point you're making is you don't have a concern about multiple cycles of whether it's HA or multiple cycles of cortisone. Sounds like if you had to pick.
Not for end stage. Once there's no cartilage left and we're talking end stage bone-on-bone arthritis, I have no qualms about giving patients multiple injections.
Okay, got it. Okay. So Derek writes, talks about strong evidence to support the use of aerobic exercise in the effective non-operative I missed that question here. So on here.
I do
effective non-operative care of knee OA. Yeah.
I do a lot of exercise counseling with folks. Something else that I frequently get told, much as what you alluded to earlier, Mo, is that I can't move, I can't do these things because my knee hurts.
Yeah.
Water aerobics actually is something that I find is very helpful, and the combination of doing an injection, getting them on an anti-inflammatory if it's something that they can systemically tolerate from a GI and a renal standpoint, and then getting them into the pool actually helps a lot. But I don't always send patients to formal physical therapy, but I do work with them on home exercises for quadriceps strengthening, as well as low impact aerobic exercise.
Yeah, and I think the point, and I'm just going to, Derek, this is in the question here, but the point I think you mentioned is, why is this not identified? I think the truth is, I mean, the guidelines do support it for sure. And if you look at tomorrow, again, we talk about the various guidelines. In fact, it comes up in every guideline. Just the way NSAIDs or topical NSAID comes up in every guideline, usually has strong support for. The challenge, I imagine, is pain, and managing pain, to get to exercise. So aquatic makes a lot of sense. You're unweighting, the joint to some degree. But that makes sense. One other question is, before we maybe close this out, question came in earlier, I missed it, around the issue of, you've got sort of those who are quite active with knee OA, right? They come in as joggers, and then they come in, they say, doc, I got arthritis now. Is it because I jog so much? I mean, you must get that all the time.
Yeah, I get that question a lot, and I generally tell people that I am not doing knee replacements in people who are marathon runners. So this is, I don't know of any evidence to support the idea that impact activities at a reasonable rate, as long as you're not getting into overuse injuries, CrossFit injuries, that sort of stuff, right? But I don't know of any evidence that actually has been successful at linking impact activities to developing arthritis. Now, I think if you're getting injured, if you have a true injury, if you have a limb malalignment that can cause to overload of the joint, either in varus or valgus, where your mechanical axis is outside of the joint line, I think that's something different. But just running a few kilometers, I don't think is going to increase your likelihood that you need to come see me in the future.
Oh, I think that makes a lot of sense. Folks, again, we're a little bit past time. We started a few minutes late. I want to be respectful of everyone's evening. Do make a point of joining us tomorrow if you like this sort of topic area specifically, and if you're interested in the evidence. We'll be deep diving into evidence tomorrow on guidelines as well. Today was really an opportunity to talk to an expert and sort of get frontline ideas around his thoughts. So thank you all for joining us, and wishing all of you a great evening. Make sure, again, if you are interested, to sign up for the other seminars that are coming up tomorrow. Much appreciated, everyone. Have yourself a great evening. Take care.
Thanks very much, Mo, for having me.
Absolutely. Good evening, everyone.